Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. Topic for this video is hypokalemia. Hypokalemia is very common in hospitalized patients and proper treatment of hypokalemia may lead to early recovery. Hypokalemia is defined as serum potassium level less than 3.5 milliequivalent per liter. It is classified according to severity. Mild hypokalemia is when serum potassium level is between 3 to 3.5 milliequivalent per liter. In moderate hypokalemia, serum potassium level is between 2.5 to 3 milliequivalent per liter. And in severe hypokalemia, serum potassium level is less than 2.5 milliequivalent per liter. Let's understand potassium metabolism first. As you know, potassium is an intracellular cation and most of the body potassium is stored inside cells. Potassium is absorbed through intestine and comes into bloodstream where potassium level in serum is maintained between 3.5 to 5.5 milliequivalent per liter. There are two important physiological mechanisms by which serum potassium level is affected. When glucose enters into cell with the help of insulin, it takes potassium into the cell. When hydrogen ion concentration increases in acidosis, intracellular potassium ion is exchanged with hydrogen ion to maintain pH in normal range. Reverse will occur in alkalosis, where hydrogen ion concentration goes down. 90% of potassium excretion occurs through kidneys and 10% through sweat and other body fluids. Excretion of potassium through kidneys is affected by sodium load to which kidneys are exposed and aldosterone level. Hypokalemia can also occur due to inadequate intake or due to excess loss, which commonly occur through gastrointestinal tract as in vomiting, diarrhea, patient on nasogastric suction in diseases like intestinal obstruction or perforation, or sometimes due to profuse sweating. In addition to actual potassium loss through body fluid, these illnesses also induces increased potassium excretion through kidneys. These illnesses causes hypovolemia and sodium loss, which increases aldosterone level by feedback loop, which in turn increases sodium reabsorption in kidneys in exchange of potassium, contributing further in hypokalemia. Hypokalemia can also occur due to shift of potassium ion into intracellular compartment, as in alkalosis, insulin use of sodium bicarbonate, anabolic state like refeeding after prolonged starvation, because there will be production of cells in large numbers using large amount of potassium. Hypokalemia can also occur due to increased renal excretion, as in mineralocorticoid excess, Cushing syndrome, use of loop diuretics, and other drugs like amphotericin B, gentamicin, cisplatin, etc. Or in rare genetic disorder like Bartter syndrome, Gitelman syndrome, Liddle syndrome, etc. Symptoms of hypokalemia depends on severity. Mild hypokalemia is usually asymptomatic. In moderate and severe hypokalemia, symptoms of underlying disorder usually predominates. Severe hypokalemia can affect multiple systems. Severe hypokalemia can cause muscle pain, cramps, or even frank placid paralysis. Giddiness, syncope, or even collapse can occur due to atrial or more commonly ventricular arrhythmias. Constipation, distension of abdomen due to decreased GI motility or paralytic ileus. Patient can complain of respiratory distress due to respiratory muscle weakness. Hypokalemia can affect glycemic control in diabetic patient and cause hyperglycemia. In workup of hypokalemia, history is often sufficient to reach at root cause of hypokalemia. Arterial blood gas analysis is helpful in detecting alkalosis. Urine potassium level, urine osmolarity, serum renin level, serum aldosterone level, and genetic studies are required for rare causes of hypokalemia. This is normal ECG complex when serum potassium level is between 3.5 to 5.5 milliequivalent per liter. As potassium level drops, T wave amplitude begins to diminish and U wave amplitude increases. With further fall in serum potassium level, ST segment get depressed, T wave may disappear and U wave become prominent. This prominent U wave can be confused for T wave. In such cases, QT interval will falsely appear prolonged. Differentiating feature of U wave from T wave is its round shape, while normal T wave is an asymmetric wave. Patients with severe hypokalemia are prone to develop arrhythmia, especially ventricular tachycardia. Patients with underlying structural heart disease, acute myocardial infarction, and patients receiving digoxin therapy are high-risk group for such events. For treatment of hypokalemia, one should remember few important points. Potassium deficit is calculated as 200 to 400 milliequivalent for fall of each 1 milliequivalent per liter in serum potassium level. Mild cases only needs oral potassium supplements. Intravenous potassium is less well tolerated because it can be highly irritating to veins. Hence, it can be given only in relatively small doses, generally 10 milliequivalent per hour. In emergency situation, IV potassium as much as 40 milliequivalent per hour can be administered through central venous line under close cardiac supervision. Oral and parenteral potassium can be safely used simultaneously. In patient with nasogastric suction, use H2 blockers to reduce potassium loss. Take ongoing potassium losses into consideration while giving potassium correction. If patient is severely hypokalemic, avoid glucose-containing parenteral fluids to prevent an insulin-induced shift of potassium into the cells. If patient is acidotic, correct potassium first to prevent further fall due to alkali-induced shift of potassium into the cell. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.